This is the Emergency Medical Minute, sponsored by Mile High Ambulance.
I'm going to present a case to you guys and then kind of challenge you to come up with a diagnosis and develop a plan for her. So let's say you've got a female patient. She's around 35 years old. She comes in with intermittent right upper quadrant pain for 2 months. It's been going on for a couple months. It's worse after meals. Each episode lasts about 30 minutes. It radiates to the shoulder. She's got some nausea and some vomiting, right? ROS is otherwise negative. No heartburn, no changes in bowel habits, no diarrhea, no fevers, no chills, nothing like that. Doesn't drink, doesn't smoke, doesn't do drugs. No family medical history. Labs, totally normal, including CBC and CMP. LFTs are totally normal. ALT, AST, normal. Bili, normal. Lipase, normal. Amylase, normal. Fasting ultrasound, right upper quadrant, nothing. No stones, no gallbladder wall thickening, no sludge, no polyps in the gallbladder. So, further workup, you do an endoscopic ultrasound to look for smaller stones, nothing. You do an EDD to look for any source of Peptic ulcer disease or something else that could explain the pain. Nothing. Totally normal. HIDA scan, 70% ejection fraction. So that's a totally normal range. Abnormal would be below 30 to 35%. So what do you guys think is the most likely diagnosis?
I wouldn't say gallbladder, but there's no stones or anything.
Yeah, I know. Yeah, I know. I threw the red herring. Yeah. Yeah. Yeah, and if we got an abdominal x-ray, that'd be normal as well. No constipation. She hasn't had any bowel symptoms.
What about narrowing of the tongue gut?
So sphincter body dysfunction, is that kind of where you're going? So that would still...
There's no stone, but you could still have a slight stricture.
Yeah, but that would still show decreased ejection fraction, right? In the HIDA scan, yeah.
You got it.
Yeah, right. So it's functional gallbladder pain, right? And so this can happen in a really small subset of the population, but I think it accounts for 2 to 5% of cholecystectomies. And so the big question is, do we cut or not cut? And so let me kind of run through what functional gallbladder looks like. And then, So it's usually associated with abnormal gastric emptying, so delayed gastric emptying, so kind of dysmotility stuff. Some recent literature is looking at the involvement of mast cell activation in the muscular wall of the gallbladder, leading to some sort of dysfunction there. The clinical picture, like I presented to you guys, looks a lot like cholecystitis, right? So that can kind of lead you to that path and think that path, but everything's going to be normal, right? The LFTs are normal. There's no positive findings on imaging. Some people have an abnormal HIDA scan and some people don't. So it doesn't necessarily mean that they don't have it if they have a normal HIDA scan. You do have to get an upper endoscopy and an ultrasound endoscope to rule out any small crystals or small stones. And so then, the question is, do we cut or not cut? Do we take the gallbladder out or not?
Not yet. You should at least try some alternative therapies before you put it into
instead of changing diet.
Yeah, totally. So, So the
Is she on a medication that can slow her gastric emptying?
She's not. Yeah. I mean, that's a good question, though. Yeah. I mean, what medication would cause this to worsen, though, actually? So semaglutide could, right? Because that would delay gastric emptying. Classically, too, any opioids generally worsen gallbladder pain, right? But the literature is kind of mixed on this. It's if it's been going on for 3 months, then it's likely that a cholecystectomy will improve the pain. Also, if they have really classic biliary type symptoms, a cholecystectomy might improve the pain. But it says if the symptoms are moderate or atypical, less than 3 months, or if they have a negative HIDA scan, then you should try alternative methods. 50% of people might resolve spontaneously as well. So, that's it for me. Any questions?
I had all those symptoms.
Yeah, but it was gallbladder.
I had a huge...
Yeah, right. That's the red herring in this.
Right.
Cool. Thanks, guys.
Thank you. Good job.
Thanks.
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.